Good evening, everybody. My name is Faris Haddad, and on behalf of the Institute of Sport, Exercise and Health, my co-chair Bevin McCartan and I are delighted to welcome you to this webinar on sports injuries, on snow sports injuries. Normally at this time of year, we host our annual meeting at the Royal Society of Medicine over a couple of days to profile what's new in sports medicine, sports injuries and sports surgery. This year, as with everything else, COVID has led to some disruption, and so we have transferred to a web-based format. Yesterday, there was an outstanding session led by Matt Wilson and Noel Pollock on adolescent sports injuries, which I would recommend you watch if you haven't watched it already. And today we have a session on snow sports injuries. We have some outstanding speakers. There are going to be 7 presentations and then some time for questions at the end. We will look out for your questions on the chat and try and make it as interactive as possible. So please do post your questions as we go along. But otherwise, we've got 7 great speakers. We will give them all a chance to answer your questions at the end. We're going to go in a fairly logical way from prevention all the way through to management and rehab, looking at various injuries from the shoulder, the knee, and the foot. And we're going to start with one of our outstanding sports physicians, Dr. Eleanor Tillett, who is leading education at ISEH and at UCL, and has been a key part of our program for over a decade now. Eleanor's kindly going to speak to us tonight about how to avoid snow sports injuries. So over to Eleanor.
Hello, my name is Eleanor Tillett. I'm one of the SEM consultants here at ISEH, and I'm very pleased to be part of this winter sports evening. Many of us are dreaming of those halcyon days where we could go where we wanted to, do what we wanted. Goodness me, even sit next to somebody on a ski lift who wasn't part of our bubble. But though sustaining an injury, let alone preventing it, seems like a pipe dream at the moment, we will all get back to our day jobs eventually. So in the interests of optimism, let's take a trip to the slopes this evening. It's much my job to set the scene. I'm going to be looking at injury frequencies and types, the risk factors for those injuries, and how we might go about preventing them. To set the context for this, I'm going to be focusing on recreational level and skiers and snowboarders. When we're looking at injury prevention, first of all, we need to know the extent of the problem, the potential risk factors, and then introduce a preventative measure and reassess the effectiveness of this. Understanding of injury prevention risk factors has evolved a lot from Van Mechlen's original model. And actually, we know quite a bit about the intrinsic and extrinsic risk factors that contribute towards winter sports injuries. And I'm going to explore that over the next few slides. But first of all, what is the extent of the issue? Both skiers and snowboarders are at relative risk of quite high risk of sustaining an injury. It's higher for boarders, probably unsurprisingly. Think about the mechanics of the two sports. We can probably predict the likely patterns of injuries. So skiers, 2 legs, 2 skis, potential for them both to go off in multiple directions and cause all sorts of carnage. So lower limb injury in skiers is by far the most common injury. In particular, soft tissue injuries around the knee, ACL, MCL, with a slight excess in female skiers, as we see in other sports with non-contact ACL injuries. Ski binding mechanisms are particularly important here. So if they don't release correctly, if they've not been set correctly, that will increase the risk of ACL and other soft tissue knee injuries. The other common injury for skiers is around the thumb, so a fall on an outstretched hand over a ski pole and damage to the ulnar collateral ligament. Also of note, the other significant area of risk for injuries around the spine, with or without neurological injury. If we think about snowboarders, very different biomechanics. So both feet fixed in one spot. So falling on an outstretched hand, the highest risk of injury is wrist injury. Knee injuries are less common in boarders, but ankle injuries are more risky, are more likely to be sustained, particularly in the leading leg, though the mechanism for that is not clear. Again, spinal injuries are potential, slightly higher for snowboarders than for skiers. It's worth pulling out some specific data on head injuries, given that both sports have quite a high risk of head injury, and in particular are the most likely to cause a fatal injury on the slopes. Again, higher in boarders than skiers. So what are the risk factors that are contributing towards these injuries? There are lots of different internal and external risk factors at play here, and I'm going to pull out a few of these in more detail. Skill level is really important. Beginners have more injuries than more experienced athletes, and this is particularly the case for snowboarders. There are lots of reasons for this, so less technical ability and potential overestimating one's ability on the slopes. Being less familiar with a sport means you may be more likely to become fatigued, and you may be less conditioned going into a ski or boarding holiday. We know that the majority of injuries occur later on in the afternoon. So fatigue has a negative impact on balance, a reduced reaction time. So these are all factors that are contributing to that increase in injury risk. In addition, beginners are going to be less familiar with their equipment and also assessing the general conditions in which they're participating in. Interestingly, those beginners are far more likely to have injuries. There's some evidence that the injuries sustained may be more severe in experts, probably because they're doing things faster and at a greater technical challenge. Contrary to popular belief, it's not all the snowboarders' fault. There's a common myth that snowboarders colliding into other people on the slopes are the most common cause of injury. In fact, isolated falls, people skiing and boarding on their own account for the vast majority of injuries. Even when two athletes do collide, the risk of injury is less than from isolated falls. It varies between studies up to about 21%, and this variation is probably due to the different densities of participants in different resorts. However, if two athletes do collide, it's more likely to be two skiers rather than a skier versus a snowboarder, so we probably need to let them off the hook a little bit. Lots of external factors at play here, so snow conditions, the icier it is, the greater the risk of injury, and in particular the risk of concussion on ungroomed or rough snow. Poor weather and visibility means you can't see to navigate around obstacles or prepare for changes in the snow conditions. And as we've talked about, the importance of equipment, being familiar with it. Sometimes older equipment may be not as well maintained, and if bindings aren't properly adjusted for a skier's weight and height and ability, then that can contribute to their risk of injury as well. So how can we prevent these things? There are different types of prevention that we can look at. We can look at things focused on equipment, on education, behaviour of people on the slopes, their experience, and also third-party involvement. Most studies have focused on equipment and behavioural approaches, but as you'll see from this list, what's missing is a sort of exercise-based injury prevention programmes that we're used to in other areas of sport. What we do know is helmets are good. They reduce the risk of injuries, head injuries significantly. Wrist guards, the evidence base is less clear. They may reduce the risk of wrist and forearm injuries, but the concern is that by fixing the wrist, you end up with just transferring the force more proximally to the upper limb and ending up injuring the elbow or the shoulder instead. So there isn't sufficient evidence to universally recommend wrist guards in boarders, but they may be of benefit, particularly to beginner boarders. Ski equipment needs to be properly maintained. and appropriately adjusted ski bindings and regularly sharpened skis, particularly for icy conditions. Interestingly, taking ski or snowboard lessons has not been shown to reduce the risk of injury. Probably because of focus in those lessons being more on skill acquisition than safety. So they're not taught necessarily to assess snow conditions or understand the challenges of a run that they're about to undertake. There have been a couple of studies back in the 1990s that looked at video-based exercise programs to reduce the risk of injury in skiers. These did have a beneficial effect. However, the sport and the equipment has moved on a lot since then. The movement patterns and the exercises that were looked at in those studies aren't really so relevant now. It's a good principle for an approach, and you'll be hearing from speakers later on this evening about specific injuries and prevention approaches towards them. We know from other sports that appropriate neuromuscular training can have a significant positive impact on reducing injury. But there aren't any good studies in recreational athletes in snow sports that we can apply at the moment. So this is a question of looking for individual advice before going on a ski holiday at the moment. So wear a helmet, stop before you get tired, don't overestimate your ability and be aware of the environmental conditions. Use appropriately adjusted and well-maintained equipment and be fit for the activity with appropriate neuromuscular training and strength and conditioning beforehand. Maybe come and see one of our ISEH physios for further advice about that. And enjoy the rest of the evening.
Thank you, Eleanor. That was outstanding. It's great to have such a good baseline for the rest of the sessions. And ideally, if everybody followed your advice, we wouldn't need all the rest of us. Now it's a great pleasure to introduce Professor Mike Loosemore. Mike doesn't really need any introduction. He is one of the leading sports physicians in the UK, and he sometimes tells me in the world. Above all, in relation to today, he's the Chief Medical Officer of GB Snow Sports, as well as being CMO of GB Boxing. He's extremely experienced, and he's just the sort of person who can give us the right advice on how to initially assess and investigate these injuries, and to answer the very important question of whether you treat locally or transfer back home. Over to you, Mike.
Hello, my name is Mike Loosemore. I am the Professor of Sport and Exercise Medicine at the Institute of Sport, Exercise and Health, and I'm also the Chief Medical Officer for GB Snow Sports. I've been asked to talk today about the initial assessment and investigation, treat locally or transfer back. So initially, it's really a case of whether you're on the ground in the foreign country or not. Initial assessment investigation when you're on the ground can be challenging. And this depends whether it's at the competition venue or the local hospital. The pictures here is of the Pyeongchang Olympics, and it's the blood wagon picking up somebody from the slopes. And at Olympic Games or a big games, often the people there are not used to being at an Olympic Games because they only happen every 4 years. And also the competition venues are brand new. Everything is literally either in the box or just out of the box. And people have not had a chance to acclimatise or work in the venue regularly. So often they're not entirely sure where everything is. Local hospitals can vary. This is a picture of the trauma centre which we used at the Pyeongchang Olympics. It was 40 miles away, and there was road or helicopter transfer there. Interestingly, this picture shows the corridor, which is set up with oxygen and electric points all the way along the corridor so that you can fill the corridor with beds if there's a an earthquake, or in South Korea's case, a nuclear attack from the north. And it's a great hospital, very high standards, so no concerns about the hospital there. So who should you transfer back to the UK? Well, I guess you really want to transfer everybody back to the UK. Why wouldn't you? In the UK, everybody speaks the same language. There's a very high standard of practitioners. There's great hospitals where people can be treated with all the latest technology. And also, if you do have to have an operation or an intervention, then you have got follow-up. And if there are complications of those operations, then you can also be followed up and seen by the same people who've done the operation. So transferring back to the UK makes complete sense. So why would you even think about leaving an athlete abroad? You know, what advantage is there? Well, obviously, if the athlete's too ill to come home and is requiring full intensive care, then it's very difficult to transfer them home. If they're very ill at home and you feel that they're not getting the care that they require in the country that they're in, then it may be worth looking at airlifting them back to the UK. And that can be done, but it's very difficult. So the other thing is, of course, if urgent treatment is required. So if they have a fracture dislocation of the ankle, for example, and they have lost their blood supply to their foot, then they may need urgent intervention to save the foot. And also, there are world-class people abroad. There are fantastic doctors and surgeons who may actually do a really fantastic job for your athlete without transferring them back to the UK. And of course, one of the great advantages of coming back home is that all your family are there who can look after you and take care of you. But for example, we have a cross-country team who are based in Norway near Trondheim, and all their support is in Norway. Their family, girlfriends, coaches, etc. are all in Norway for them. So they'd rather have any medical intervention in Norway. So I thought probably the best way of illustrating this was to give you a case history. And this case is about a young snowboarder, female snowboarder called Katie Ormerod, who has given me written permission to talk about her case. And she injured herself at the Pyeongchang Olympics, going from the rail here and unfortunately hitting the knuckle of the downslope as she came off the rail. They were practicing, so it was just before the Olympics had started, which is not a good time to get injured for lots of reasons. And she hadn't got enough speed coming into the rail. They'd come off the rail without enough speed and hit the knuckle of the downslope. She immediately knew she'd done something bad to her foot. She couldn't move and was in a lot of pain. It turned out that she'd fractured her calcaneum. And when she'd landed and dorsiflexed her foot, as she wears soft boots, the Achilles tendon had literally pulled the calcaneum in half, which, as you can imagine, was quite sore. The other problem was that when they took her down the mountain to the medical tent, or the medical clinic at the bottom of the mountain, as I mentioned before, this was brand new. It was before competition had started, and a lot of the stuff was still in the boxes. one of the pieces of equipment that was still in the box was the boot cutter. So the medics couldn't locate the boot cutter. And as you can imagine, with this injury, pulling a boot off is quite painful. And as you can see, Katie tweeted afterwards that it had taken the medics over an hour to pull the boot off. The other problem was that they had no real analgesia available, only intravenous Voltarol, which they were only allowed to use once. So she had a very unpleasant time just getting the boot off. She then had to be transferred to the trauma hospital, and they put her in a square foot splint. And as you can imagine, with that injury, dorsiflexing the foot was not the most comfortable thing to do. It was then a case of whether she'd be airlifted to the hospital or taken by ambulance. It's 40 minutes by ambulance, but 20 minutes by helicopter. The only problem is that to get the helicopter to the venue took about 30 minutes because the helicopter was located quite a long way away. And then they had to get her into the helicopter. So it was decided that it would be quicker to actually transfer her by ambulance, which they did. Fortunately, when we got to the hospital, we got some advice from James Calder in the UK, and he said this needs to be operated on very quickly because of the risk of avascular necrosis at the back of the heel where the skin is stretched. Fortunately, the medics did take this on board, and the other advantage was that James knew a first-class surgeon who was in Seoul, who had a world reputation for foot and ankle surgery. So she was then transferred to Seoul, where the ankle was operated on. So initially good results with good restoration of anatomy. But unfortunately, as predicted, she'd lost the blood supply to the back of the ankle, and the necrosis started from the inside. It was at this stage that it was decided that she should be transferred back to the UK because the ongoing care of this was going to take several months, and it would be better done in the UK. So she came back and saw the plastic surgeons and had several skin grafts. In the end, I think she had 7 operations on the skin overlying the ankle to get it improved. And to end the story on a high note, a year later, after a huge amount of rehabilitation and some fantastic work by the doctors, the physios, the strength and conditioning coaches, the nutritionists, she became Britain's first World Cup snowboard champion, and in the end had a very successful season. So I hope that was of use. Thank you very much.
Faris, I think your mic is muted.
That's a wonderful job, Mike. It was so good. I muted myself because I didn't want to interrupt you. But it's amazing and shows the great resilience of some of our athletes like Katie being able to get back from such a devastating injury. I'm sure there'll be lots of questions about what should happen to weekend warriors who are out there on the slopes when they're injured, and we'll come back to that in the discussion session. Now it's a great pleasure to introduce Mr. Carlos Cobiella. Carlos leads our upper limb unit at ISEH. He's well known to most of you as a shoulder and elbow surgeon, and today's task for him is to cover up for us shoulder injuries, both dislocations and fractures in snow sports, the management and recovery expectations. Over to Carlos.
My name is Carlos Cobiella. I'm ortho surgeon with an interest in shoulder and elbow conditions. And today we're going to talk about injuries of the shoulder that happen commonly in snow sports. What is the shoulder? The shoulder is not a joint, it is a girdle and it's composed of several joints. The bones that compose it are the clavicle, the scapula, and the proximal humerus, and these are connected through ligaments and capsules to form the joints. Let's talk about the different areas that are commonly affected. The proximal humerus is a common one, and I see this not as a bone, but as a unit between the muscle, the tendon, and the bone. It's the insertion of the superior cuff, and these are areas that, when injured, can affect the tendon itself. You can see here a rupture of the supraspinatus tendon, which is an acute traumatic one. They can affect the proximal humerus with fractures of the great tuberosity, or they can affect both, as in this case. The first thing to do is to diagnose them, and very commonly this will be a very difficult task, as we can either see very subtle changes, as you can see here, with a little line that goes across the great tuberosity, or even a normal X-ray. Therefore, an MR scan is quite important when patients present with pain and dysfunction of their supraspinatus, as we can then identify the level of the injury. And this will determine how we manage them, because undisplaced fractures, which are commonly the way they present, will require very little management other than initial control of their pain and then some physiotherapy rehabilitation. Displaced ones will require internal fixation, and if the cuff is affected, then an arthroscopic cuff repair is recommended, as acute traumatic cuff injuries are completely different from degenerative ones, and their outcome is much better if they're dealt with acutely. Independently of what areas injured, the recovery will be very similar. There'll be an initial period of stiffness and weakness while the healing occurs, and this will be particularly noticeable in the first 2 weeks. By 3 months, they have reasonable function, but it takes a long time to get full recovery. Whether it's a fracture or a cuff tear, we can expect symptoms to persist for 9 to 12 months. Let's move on to the glenohumeral joint, and dislocations of this joint are a surgical emergency. They require an initial neurovascular assessment, as injuries of the plexus and particularly the axillary nerve are very common and need to be assessed. This should be followed by emergency treatment, which is a close reduction. I find that simple traction, even without sedation, just very gentle, sustained traction for 5–10 minutes will usually result in muscle fatigue and spontaneous relocation. If that doesn't work, there's many other maneuvers that can be tried, and even sedation and analgesia given. How do we manage these? Well, acutely, if there is involvement of the glenoid rim, and it is significant, then a surgical repair would be recommended. And this is also a valid option, a very valid option in young adults, particularly under 16. In adolescents under 16, the rate of recurrence is extremely high. It's over 90%. And this continues to be high until the age of 23. So in these, one of the options would be an acute repair of their labrum. Otherwise, they can be left and physiotherapy support to get the movement back. And once they're comfortable enough, they can be assessed through an apprehension relocation test. This will determine whether they are recurrently unstable or not. A positive test is a sure indication of recurrent instability, and that they will have another dislocation. Imaging will help us determine if the problem is in the capsular-labral complex or if it involves the glenoid. If it does, then a CT scan will be highly recommended. And this leads us on to management. A labral repair will be that is recurrently unstable, can be repaired arthroscopically, and that's a very common procedure with very good outcomes. If the glenoid is involved, then a similar procedure can be undertaken, and the bony fragment reduced with the labrum and repaired that way. There's several techniques, including the Sugaya technique, that are very helpful. If the fragment is very comminuted and the defect significant and cannot be repaired, then a bone graft can be done at the same time, arthroscopic islet crest bone graft to increase the surface of the glenoid and then do a labral repair on top. Another option is to proceed to lateral procedure. Again, independently of what the procedure has been, the progress is very similar. The first 4 weeks will ask them to limit their range, particularly in external rotation beyond neutral, to avoid damaging the repair. And after this, they start a course of physiotherapy with progressive mobilization and working on dynamic stability. Usually by 10 to 12 weeks, they can start their end-stage rehabilitation or contact training, depending on their sport. And return to contact sports is fairly consistent at 4 months. Looking at acromioclavicular separations, these involve 2 sets of ligaments, the acromioclavicular ligaments and the coracoclavicular ligaments. Depending on the amount of energy that goes through this area, these can result in a sprain of the acromioclavicular ligament, type 1 injuries, a rupture of the acromioclavicular ligament, type 2, and then rupture of the coracoclavicular ligaments, which are grade 3 and above. These will result in a complete separation of the upper extremity from the axial skeleton and can cause significant functional impairment, particularly in overhead activities. So, in grade 3 and above injuries in sporting individuals or overhead loading occupations, it is a very valid option to proceed to an acute repair within 2 weeks. Beyond 2 weeks, it's very difficult to get the ligaments to repair themselves. Otherwise, they can be left and assessed at a later date. And if they have persisting symptoms, a reconstruction can then take place. We can't do an acute repair, but a reconstruction, whether with autograft, allograft, or synthetic ligament, can be undertaken. Again, the rehabilitation for all of this is very similar, avoiding movement above shoulder level for the first 6 weeks, or any loading or lifting in that time, and then progressive mobilization. Usually by 3 months, they have a very good range and they're able to return their sports, even though contact, I tend to wait for an extra month. What are the options for an acute repair? We reduce the coracoclavicular distance. That can be done with this device very easily, a tightrope. It can be done open or arthroscopic. Arthroscopic techniques are very popular. However, an important part of this procedure is to repair the acromioclavicular ligaments, and that must be done open, and therefore a small open incision done at the end of the procedure if it's done arthroscopically. There are certain fractures of the lateral clavicle that should be thought of as injuries to this ligament complex. And if you look carefully here, there's this little bony fragment that is still attached to the ligament, and the rest of the clavicle. They should be in a very similar way, reduction of the coracoclavicular distance, and then fixation of the fracture, which can be done either by cerclage with tape or open reduction or with a plate fixation. And other devices that can be used for this kind of fracture are hook plates, although shoulder surgeons tend not to like them because they violate the subacromial space. Clavicle fractures are common and mostly thought of as benign and without consequence, although very recent multi-center trial has shown that there's significant rates of non-union. These are usually associated with certain patterns, particularly when there's significant displacement or shortening of the fracture. High energy injuries that manifest themselves with comminution or intercalated segments are also known to have a higher rate of delayed or non-union. And other conditions that might sway us towards open reduction and internal fixation are when there's compromise of the soft tissues, open fractures or tenting of the skin. More rare fractures or injuries involve the sternoclavicular joint. These are significant if they are posterior dislocations, as they can compromise the big vessels behind. Anterior ones are generally benign, and they cause cosmetic deformity. If they actually cause problems, then they can be addressed surgically. And other injuries, which are more a consequence of collisions rather than falls, are fractures of the scapula. These can usually quite impressive on imaging, but can be treated conservatively, as the muscles and tissues around them can hold them in place. If the medial column is affected, or the lateral column is affected, or the glenoid is involved and is displaced, then those should be fixed internally. And this is the end of the talk. Thank you very much for your attention, and thank you to the ISEH for organizing this.
Thanks, Carlos. That's some great points there on how to manage some tricky, complex shoulder injuries, and also good pointers on timeframes that we might be dealing with when dealing with these athletes. Next up, we have Mr. Mike Oddy. He's a foot and ankle specialist surgeon at ISEH and UCLH. He's been one of the surgeons involved at the London Olympics in 2012. He's involved in a lot of national research around foot and ankle conditions, and he's also one of the orthopaedic leads for our UCL medical students. He's going to give us some talk today on snowboarder's ankle. So over to Mike.
My name is Michael Oddy. I'm a consultant trauma orthopedic surgeon. I work at ISEH. I'm very grateful for the invitation to speak at this ISEH and HCA webinar. I'm talking about snowboarder's ankle, and I'm going to start by just outlining the fact that any injury in sport, one needs to consider both generic injuries versus specific to the sport in question. So whenever there's an injury in sport in the ankle, one needs to consider predominantly soft tissue or bony injuries. The soft tissue components, which I'm not really going to cover, one should consider lateral and medial ankle sprains, high ankle sprains such as syndesmosis injuries, peroneal tendon injuries, and retinacular injuries, which can be very relevant in this case. Fractures by mechanism, there can be axial loading injuries, both pilon, so articular distal tibia, or the calcaneum, rotational malleolar injuries, and dorsiflexion injuries, which traditionally can injure the talus or talar neck. There can also be osteochondral lesions of the talus. The key thing that I wanted to highlight in this presentation really are that there are other injuries, one being very specific, which can masquerade as a soft tissue injury, and specifically may be missed if one applies purely the Ottawa ankle rules. And they can include, where I've outlined with a circle, the anterior process of the calcaneum, but specifically the lateral talar process, which has been abbreviated to the LTP. Snowboarding obviously arose later than skiing, but the rate of injury seems to be higher than skiers. To someone who doesn't work in a winter sports predominantly location, some of the actual the figures such as injuries per 1,000 snowboard days can seem a little abstract. But most reports of snowboarding series of injuries suggest that the ankle is injured in up to about 15% of cases. Kirkpatrick published quite a large series of snowboarding injuries, and again, 15% were of the ankle. Roughly equal numbers were soft tissue injuries and fractures. And specifically, if we break down the fractures, just under 2/3 were malleoli and 1/3 were of the talus. And the specific interesting point is that of those talar fractures, 95% were of the lateral talar process, which equates to about 2.3% of all injuries. Of note, particularly from snowboarding, the leading foot is injured in just under 2/3 of cases, although that doesn't affect the injury pattern. And in this particular report, there was no significant correlation with the type of boot, although looking at the literature, that has evolved over time. If one compares the rate of the lateral talar process fracture with the general population, it is significantly higher in snowboarding than the general population. From a historical perspective, the first major case series dates back to the 1960s of lateral talar process fractures. And Hawkins described 13 cases, interestingly, one case of which was from a skiing-related injury, and for a piece of bone, which is probably not much bigger than one's thumbnail, an 8-week period in a long leg plaster seems quite extreme. They classified injuries into 3 types, which I labelled on the right and outlined the fracture pattern. So type 1 fracture is a large lateral talar process fracture, which involves both the ankle joint and the subtalar joint. A type 2 is a comminuted or multifragmentary fracture pattern, and a type 3 is a very small chip of the anterior inferior margin. And interestingly, they concluded that unexplained persistent pain around the lateral ankle after an injury with particularly dorsiflexion and inversion can often be caused by a lateral talar process fracture. This was eponymously or named rather a snowboarder's fracture in the early to mid-1990s. And interestingly, this was actually from a single case report in a family practitioner journal. This was of a patient who was able to weight bear and presented to their GP and subsequently had investigations, both plane and 3-dimensional, and underwent a fixation, and was subsequently named as a snowboarder's fracture. A different group broadened the term snowboarder's ankle to include this fracture pattern. And interestingly, they changed the classification from the 1960s to a different form, such that type 1 is an anterior inferior chip, possibly an avulsion from the ATFL. Type 2 is a large single fragment which can be displaced or undisplaced, and type 3 is a comminuted fracture. And interestingly, again, they commented that the location of the fracture is inferior to the lateral malleolus and therefore not covered necessarily by ankle Ottawa rules. One needs to be careful to image appropriately, and that may include ankle and foot radiographs, if necessary, a specific Broden view of the subtalar joint, or more commonly now CT scan for 3D imaging. There has been a cadaveric study which has supported some of general observations on the behaviour around the subtalar joint. The subtalar joint has an oblique axis, and when one inverts the hindfoot, as the calcaneum inverts under the talus, it tends to slide forwards, such that for the right foot it behaves like a right-handed screw, and for the left foot it behaves like a left-handed screw. And as that sliding action occurs, as you approach full supination, this particular study showed that the subtalar joint, the talocalcaneal joint, becomes incongruent. And at a certain point, the force is applied directly to the lateral talar process. So they postulated that the main mechanism for a lateral talar process fracture is a dorsiflexion supination injury mechanism with various stages from an undisplaced position to a displaced fracture, which can then progress to a subluxation of the joint. The case series has looked at the literature of the reported cases, and they adopted it based on Hawkins' classification from the 1960s. So when Pereira and the team looked at that series, type 1 fractures, which were constituted by about 42% of injuries, the operative group did well, with only 88% having mild or no symptoms. The non-operative group for the single large fragment had a poorer outcome, with over a third of the patients having moderate and severe pain and stiffness, and almost half of the patients underwent late surgery, including up to a quarter of them underwent subtalar joint fusion. In the type 2 comminuted fractures, there was generally a better outcome with early excision of the fragments versus non-operative treatment, but a high proportion of patients presented late, more than 2 weeks post-injury, and of those, about half of them had to undergo salvage surgery. The type 3 small chip fracture generally treated non-operatively, but the evidence would suggest that there is a better outcome if there is some degree of immobilization. Again, over a quarter of the patients presenting late, meaning more than a couple of weeks post-injury. This series I've just included specifically because it was one series of 20 patients, and the outcomes followed up to 3.5 years. The key interesting points were that the patients in this group reported that they believed the mechanism to be this dorsiflexion external rotation and eversion, which doesn't match the classic view of a lateral talar process fracture of being dorsiflexion supination. At 3.5 years, about 15% of patients had developed subtalar joint arthrosis undergoing surgical intervention, and about 1/5 of the patients hadn't returned to the same level of sport. Generally, the outcomes were better in terms of ankle foot scores for operative versus non-operative treatment. And this group also published the stress test specifically for the lateral talar process, which includes dorsiflexion, external rotation, eversion, with thumb being in the pressure really where this bottom arrow is going to be anterior and inferior to the tip of the lateral malleolus. So when we looked at some specific cases, I think we probably see this injury far more common than one would normally consider. You can see I've marked this is a small chip around the lateral talar process. We often see small bony ossicles in the subfibular region and may well interpret them for being avulsions from the fibula rather than the lateral talar process. I would personally treat all of these as a soft tissue injury with a tiny bony component, and I would tend to weight there as tolerated in the boot, aiming for early range of movement. One clearly has to keep an open mind for more sensitive imaging, such as an MRI, specifically looking for unresolved pain, such as bone bruising, osteochondral lesions, peroneal tendon injuries, or synovitis. This is a different injury, and whether one classifies McCrory type 2 or Hawkins type 1, the top 3 images on the right, one can see the lateral talar process. One has to be very careful about what one's interpreting, but there is a displaced lateral talar process fracture. It's very difficult to see on the lateral view, but the CT gives a dramatic appearance. This has been fixed with a headless compression screw, 3mm headless compression screw. One can see the CT scan post-operation shows a good congruent joint with union. I would wait there in a boot after the initial healing period rather than a plaster. But the interesting point I've highlighted is that this patient also had an avulsion of the peroneal tendon sleeve of the retinaculum, where this was a stable injury and not required repair. Finally, it's worth pointing out that this is a different injury. It's a displaced talar neck fracture, but at the time, the patient also had a displaced lateral talar process fracture, and I opted not to fix that. And interestingly, at 2 years post-injury, there's no talar-doma avascular necrosis, but there's probably a fibrous non-union, albeit asymptomatic, of the lateral talar process. In terms of summary of lateral talar process fractures, the so-called snowboarder's fracture or snowboarder's ankle, if there is a single large fragment undisplaced, it can be treated non-operatively, either in a plaster or a boot. A displaced fracture, nominally considered to be more than 2 millimeters, would be fixed, and I would tend to use a headless compression screw. Comminuted fragments can be excised, whether that's formed early, late, or my preference would be if symptomatic. And generally, small chip fractures would be treated as if a soft tissue injury, so weight bearing is tolerated in a boot. So in summary, a snowboarder's ankle, one should really consider as any ankle injury in a snowboarder, but should keep the differential diagnosis quite broad. The specific snowboarder's fracture, which sometimes gets called a snowboarder's ankle, is that of a lateral talar process described in the early to mid-1990s. In some series, that can constitute about 95% of non-malleolar fractures and about 2.3% of all snowboarding injuries. The key thing is that the Ottawa ankle rules may miss this injury, as it may not be supported by the rules. There can be a specific stress test, so with the foot dorsiflexed, everted and external rotated, there will be a localized pain anterior and inferior to the malleolus. Treatment really is symptomatic or non-operative for very small chip fractures, and fixation will depend on the size of the fragment. I'd like to finish there, and thank you very much for your attention, and I'll be happy to take questions.
Thanks, Mike. That's great to highlight how much more complex these winter sport ankle injuries can be, and also potentially how much pain a winter sporter might be used to tolerating. So next up, we have Mr. Sam Oussedik, who is one of our leading knee surgeons working at the ISEH and UCLH as well. He is the clinical director there of trauma and orthopedic surgery. He's going to educate us on the more complex topic of tibial plateau fractures. So over to you, Sam.
Good evening, everyone, and thank you for joining me on this talk for tibial plateau fractures. And these are potentially important injuries because they can be quite debilitating, particularly if not managed as well as they could be. So what I'm hoping to cover in the next 10 minutes or so is run through the tibial anatomy. We're going to talk about radiographic interpretation, X-rays being the means by which we diagnose these. And then I'm going to talk about some case examples just to illustrate some of the principles we use when managing these injuries. So typically, these types of classification system are used. On the left is the Schatzker system. And what these tend to do and be useful for is to both describe the injury and also to perhaps help in planning their surgical treatment. They're not that great at talking about the prognosis or the long-term effects of having these injuries, simply because the different subclassifications contain lots of different variations which can in turn have an effect on the outcome. So I tend to break this down into 3 different things which are affected by tibial plateau injuries, and one could possibly use something similar for most intra-articular injuries. So 3 interplaying criteria are going to be involved. First of all, there is joint congruence. So this is clearly important. We need each of the surfaces to meet well with the other in order to avoid peaks of pressure which may predispose to dysfunction and later degenerative change. Stability is very important, particularly around the knee joint where we have large forces at play, and intra-articular structures are going to be involved in providing that. So restoring stability after injury is also important, also to allow early range of motion to be restored. And then finally, alignment. So the alignment across the knee in particular is very important. This will have a strong effect on the forces crossing the joint, and thereby, once again, perhaps both its stability and also the ultimate chance of it developing post-traumatic arthrosis. So if we look at congruence, and here's an X-ray of a knee, AP and lateral. In fact, this one does have an injury, and we'll look at that a little bit closer later. However, as we talk about congruence, what we're really interested in is how the tibial surface, the tibial plateau, meets the femoral articular surface, red and blue lines here. And what we're extrapolating from these radiographs, of course, is what's happening to the cartilage on the inside. And so if we look at this MRI image, we can see that there's the femoral cartilage, chondral surface, the tibial chondral surface, and the menisci in between. And what we want is for those surfaces to conform perfectly one to the other in order to reduce the pressure that crosses the joint, thereby improving the longevity of the articular surfaces. The next consideration is alignment. So if we drop a line from the center of the hip through to the center of the ankle, where that passes through the knee joint is where you're going to get maximal force developed. It may also have an effect, of course, on the moments developed across the joint, and thereby affecting both stability and long-term wear. So with a varus knee, we may get an adductor moment. In terms of stability, this will tend to distract the lateral side of the knee, compress the medial side of the knee, and so any injury on the medial side affecting the articular surface may have a disproportionate effect on the forces going through the cartilage. And of course, if we have a valgus alignment, then all of those forces are reversed. Alignment, though, also involves the lateral view. So here is the tibia. We can look at the tibial slope. Why is this important? Well, again, it has an effect on the stability of the joint. As axial load is applied across the knee, so with a posterior slope such as this one, you will develop an anteriorizing force. And in the context of disruption to the anterior cruciate ligament, which will act as a passive restraint to this, then that may have a disproportionate effect on the laxity and therefore stability of the joint. So if we have depression across the posterior aspect of the tibia, increasing tibial slope, that may increase that anteriorizing vector, as we can see here. Can be on joint stability. So the articular surface of the tibia and the intercondylar region, those regions are very important as attachments for the various structures which act as passive constraints across the knee. Both ACL, PCL, and insertions of the menisci are involved. So we can see this is where an ACL would be inserted, and therefore if the fragment on the tibia is disrupted, the ACL function is also disrupted. And a similar story can be seen with the medial collateral ligament. If the medial side of the tibia is significantly disrupted as it was here, then the MCL can also become dysfunctional. Here, in addition, the ACL is involved with that eminence fracture in the central region. So those are the principles, and we can now start to look at a few cases just to illustrate them. Case one is a 28-year-old personal assistant who came to see me with a skiing injury. The initial radiographs, and we can see that there's a central eminence fracture. So the anterior cruciate, which would be inserted onto that region, is now defunctioned. And so treatment here would consist of containing any laxity that would evolve following the injury, reducing the joint instability that may be as a consequence of destabilizing the ACL. And here we have the opportunity to do that in a relatively straightforward fashion by restoring that fragment back to its position and stabilizing it there. This can be done in a variety of ways, but increasingly it can be done arthroscopically. We do, of course, have treatment options. We always do, and non-operative management is always a viable option for any patient with this type of injury. That would involve bracing, a period of non-weight bearing, and a chance of secondary ACL reconstruction should instability develop. However, we do have an opportunity at this early stage when they present to offer arthroscopic assisted fixation, which allows early restoration of range of motion, partial weight bearing initially, rapidly progressing to full weight bearing, and reduces the chance of needing an ACL reconstruction further down the line by restoring normal anatomy. So we can see the effect this would have on joint stability primarily. And so this is what we tend to do. We pass sutures up through the anterior cruciate ligament. This is an arthroscopic image, and pass that down through tunnels in the tibia and tie them off at the front, thus stabilizing the fragment and restoring tension in the ACL. This is what it looks like post-operatively. So we pulled the fragment down by passing sutures through the ACL, down through a bone tunnel secured at the front of the tibia. Case two is reasonably similar. This was a 28-year-old office worker who also had a skiing injury and is a keen runner recreationally. And so this is a slightly more complex fracture pattern now, which extends across to the medial tibial plateau. Now we have an issue not just with joint stability through the ACL injury, but also potentially a loss of congruence with the injury extending up to the medial plateau. Here is the CT image showing the fragment of the eminence avulsion. There's also a fracture extending across, as we can see there posteriorly. So a larger fragment, but still destabilizing now with also the joint congruence, which is affected. We do, once again, have non-operative measures we can institute, fairly similar to the last one of bracing, non-weight bearing, again, a chance of secondary ACL, and also a slight loss of congruence. However, once again, we could stabilize this fragment through arthroscopic assisted fixation, early range of motion, partial weight bearing, and again, reducing the chance of ACL reconstruction and hopefully restoring joint congruence. So this can be done in this case by using a tiny plate, effectively, a button passed through arthroscopically, secured through a tunnel, thereby reducing the fragment and holding it in position, allowing early range of motion to be restored. Case three, now this is a slightly fracture type of thing we see more commonly with road traffic accidents rather than necessarily sporting injuries. This is a 24-year-old chap who did have a road traffic accident, in fact, he was on a scooter and came off. It was an isolated knee injury, so no other traumatic injuries. Here's the CT, and this is fairly interesting in so much as both sides of the plateau are involved. You can see an eminence fracture in the intercondylar region, so the ACL has been destabilized. But importantly, also, there's a large medial fragment. So that's the dominant fragment in this fracture pattern. And attached to that will, of course, be the medial collateral ligament. So we have options here, which can include non-operative options with plaster casts, non-weight bearing, how long for? Perhaps 3 months. Or I think most people would agree this is a good case for operative fixation in order to restore the joint congruence, also to improve the alignment and to restore joint stability. So really all three of those factors that we've really been talking about through this plateau talk. This was what we did, in fact. We used a plate passed almost percutaneously through a mini approach, managed to get some good purchase in that dominant medial fragment, restore it back into position, and then fix the lateral part through a separate incision with a lateral base plate. That restores joint congruence, restores joint stability by getting screws into those central regions and restoring the central pivot, and then allows early range of motion to be restored. So in fact, this chap had a pretty accurate reduction of his articular surface, good rigid fixation with those plates and screws, allowing early movement to be restored. And so he had an excellent range of motion, had a good result actually, back to work after just 2 weeks, and was walking pain-free at 3 months at his last follow-up with us. So I think the key parts of this are really to offer patients early expert assessment, recognise through an accurate diagnosis that these types of injuries involve loss of congruence, potentially loss of alignment, and also loss of stability. And each of those factors needs to be considered when suggesting the optimal treatment method. Early definitive surgery, when required, always allows an earlier return to function by allowing early range of motion and hopefully earlier weight bearing as well. Thank you very much.
Thanks, Sam. Important points on how important restoration of alignment and congruence are to function and good outcomes. Next up to speak, we have Professor Faris Haddad, who probably needs no introduction. He is very well known in elite sporting circles as a go-to consultant for sports injuries. He is a hip and knee reconstructive surgeon at UCLH, and he is also the director of ISEH. He has presented and published widely. He's going to discuss with us every skier's dreaded injury, the ACL, and also some knee and knee ligament and meniscal injuries. So over to you, Faris.
Hi, my remit today is to talk about ACL and knee ligament and meniscal injuries in snow sports. This is all too frequent a problem even in this day and age. So I'm going to focus on ski-related ACL injury and its optimal management, talk a little bit about the associated injuries and some recent progress in how we think about these and how we manage them. The reality is that these are still very common in spite of multiple initiatives attempting to reduce injury risk. We still see a large number of ACL injuries every winter, and the force transmitted from the ski through the boot into the knee is really quite massive. There are multiple injury variants, but the typical thing with ski injuries is a relatively high injury to the knee, and we see big bone bruises, a lot of swelling, and often a lot of pain and severe injuries. The patients will present like other ACL injuries with a noise, a pop or a crack. They'll have rapid swelling, and they'll either have immediate instability or instability later on once they try and adjust, once they're off their skis. There are multiple ways you can tear your ACL, even through skiing. You can do it through internal or external rotation or with the so-called quads active maneuver. And of course, you can do it from direct trauma where you often damage other structures at the same time. In terms of investigations, we tend to get both plane radiographs and MRI scans. Sam's going to talk more about bony injuries, but it's important to be aware of the Sagon fracture that usually suggests that there is a cruciate ligament injury. MRI scan will not only show the ACL tear, it'll give us an idea of the gravity of the associated injuries and show us any meniscal lesions and the extent of the bone bruises. The management is very variable and really depends on the patient. The elite are a subsection that require immediate management. They are sporty individuals who generally have very rapid access to care and have a quick recovery. The sporty individual is relatively easy to treat. It's a bit like treating a footballer or a rugby player. They are conditioned and relatively easy to get into a physio and then a surgical pathway if needed. One of the challenges of winter sports is the holiday maker who is perhaps not as regular an exerciser as most of our sporty patients, and they can be really challenging when they suffer these injuries and find them really quite difficult to deal with. One of the questions we're often asked is whether these should be managed on the mountainside with the local team who often offer surgery, or whether they should be repatriated. And in general, for these soft tissue injuries, it's better to repatriate and get ownership of the pathway, both surgically and physiotherapy-wise, locally. There's the big question of early intervention, often pushed for by patients, versus later intervention. The reality is, apart from the elite subsection, it's best to have a quiet knee with less swelling, full extension, good quads activation and flexion to beyond 90 in order to intervene. But again, that can be varied from patient to patient and from injury to injury. Many of the patients come back with a splint or a brace on. There's often a need for those for collateral injuries, but I think we've got to be careful by the stiffness that can be induced by these and time our surgery if it's needed relative to that. So there is a fine balance between the patient and the injury, and the decision making has to be based around that.
The injury complex, whether the menisci are involved, whether there's a posteromedial or posterolateral repair that's needed, will guide how quickly we intervene. And in those cases, there's sometimes a risk of delaying, which means early repair is warranted, particularly with some of the multi-ligament injuries. The patient's own predisposing alignment, their soft tissue issues may also guide management, so we've got to be careful with that. The biggest challenge is to face that patient's expectations, their psychology, their potential compliance with care, and their rehab potential. That can be challenging in some ski injury patients, and we need to understand that to determine how and when to intervene. And some patients need to be assessed regularly. The reality is that most patients will clarify their presentations, and it will become obvious whether surgical intervention or not is the way forward within a 6-month time frame, usually within about 3 months. If they come to surgical attention, we have to take a view as to whether they need non-operative management, whether they need repair or reconstruction. The bit that concerns us all is the natural history, and patients really worry about that. And the reality is natural history is probably set by the injury. There is a level of damage that is sustained that we cannot necessarily reverse by any intervention, be that rehab, bracing, or surgery. If, however, we're going to end up interfering, it is probably better, based on the systematic reviews that are available, to intervene early while the menisci are well preserved, rather than later on where there is meniscal and chondral damage. So preservation of native knee structure is really quite important. There's an old adage that the ACL doesn't heal. I don't think that's true. It is rare to get good quality fibrosis, but it can happen. The example on this slide was someone I saw a couple of weeks ago, several years after their ACL injury, functioning well and with a stable knee. And you can see the scar on the top of the femoral side there. There are good studies, good randomized studies, that suggest that in the non-elite population, we can try rehabilitation first at no extra cost. So patients can rehabilitate, and then we can decide whether they need surgery or not. As you'll see from the Frobel study, once it gets out to 5 years, about half the patients will have needed an ACL reconstruction. So rehab isn't for everybody, but the other half will not have required a reconstructions and will have got on with living their lives without surgery. The initial fear was that that subsection would end up with a high rate of meniscal injuries, but those requiring later rehabilitation, later reconstruction did not have a much higher rate of meniscal injury. So it's perfectly reasonable in the patient who has equipoise to consider a non-operative, good quality rehabilitation program first. And the key is good quality rehabilitation. If surgery is required, there have been proponents who have been very loud on social media and in the lay press for ACL repair. The reality is that's only suitable for a tiny subset of injuries, usually avulsions off the femoral side. There's little evidence that it's better than having an ACL reconstruction. It does push patients into acute surgery, and we've done 3 or 4 revisions in the last year from patients who've had ACL repair, and it's akin to doing a revision ACL reconstruction because you're having to remove hardware. It really is not always that straightforward. This is an area that needs more study. So the current offerings are not quite right yet. They're only suitable for a small number, but in future, the concept of a bio-enhanced scaffold that we add cells or growth factors to that can really restore an ACL is a very attractive one. The reality in this day and age, in 2021, is that reconstruction is still the mainstay for those patients who are active and want to get back to sport. It'll be the patient's associated injuries like meniscal tears, their symptoms, their perception of instability or their sport or their work that will dictate that they need surgery. But the reality is we can reassure those ski injured patients that they can get stability and function back with high satisfaction rates. Other factors come into play. Meniscal damage, so preserving menisci is a big part of why and when we intervene. The key is to define those patients with good rehab potential. If they are committed to doing what it takes to get better, then we have a pathway they can follow that addresses the ACL and any other issues that need to be dealt with at the time and gives them a journey back to sport and full function. There's a lot of noise about graft material. In reality, you can use BTB, hamstrings or quads tendon, all do extremely well. We're less keen, particularly in the younger population, on allografts and artificial ligaments. They are more likely to fail over time. And if needed, you can always use the contralateral knee if someone, for some reason, cannot have that knee used. We're increasingly doing extra-articular tenodesis, particularly in those who are strongly pivot positive, those who are hypermobile, those involved in elite sport or needing to get back to sport early, and other high-risk individuals, such as late teens and early 20s, and of course, in the revision cases. The outcomes vary. In the elite, they're excellent. In others, they're still very good, but nowhere near as good, and that's probably based on adherence to rehab and access to care. Over 90% will get a stable knee and not need further intervention, but less than 75% will return to their previous sport. In terms of skiing, we know that we can give them a stable knee that they can get back to the slopes if they wish to the next season, often with a brace, both for physical and psychological help. If they've got a meniscal tear, we deal with it at the same time. It doesn't change the rehab. Most associated MCL tears are braced and then the ACL reconstructed and the MCL dealt with at the time if needed. If we're worried about taking hamstring in that setting, we can use a quads or a BTP graft. If they've got a posterolateral tear that's unstable, that's picked up early, it's better to repair that because a late presentation may need an osteotomy. The critical thing we're going to hear a bit more about later is rehabilitation. That is really fundamental to a good outcome, and that is probably the key for most patients. It can go wrong. It can go wrong if we pick the wrong patient. Either they've got an associated instability that we don't treat or they're uncompliant, if the surgery is done badly, which is still not uncommon, or if the rehabilitation is incomplete or unacceptable. So just to summarize, I've covered a great deal of ground, but ski-related ACL and soft tissue knee injuries are still very common and very important. They're very specific challenges that are presented here, and so the management needs to be tailored to those individual patients, and the decision-making and experience behind that is pretty critical. Some patients can be managed non-operatively and do very well. A tiny minority need ACL repair. Many will need ACL reconstruction, and all will inevitably need good quality rehabilitation. Thank you very much.
Thanks, Faris. That was great to talk about the expectations around the management and rehab of this group, particularly who might see themselves as winter athletes. So last but not least, we have Leanne Simoncelli. Leanne is one of our clinical specialist physiotherapists at ISEH. She has a master's with merit from UCL in sports medicine and exercise health. She has a specialist interest in ACL rehabilitation and also comes from the vantage point of having previously been an athlete herself. She's going to enlighten us on how to become elite amateurs by telling us how to prehab and rehab before we go skiing. Over to you, Leanne.
My name is Leanne Simoncelli. Thank you for allowing me to share my personal and professional experience when it comes to getting the best outcomes following injury, particularly in a non-athletic population. I sustained a plafond fracture in 2010 following a snowboarding accident in Switzerland. The journey of recovery was very lonely, tiring, and scary at times, but I had a great team around me, and they helped me achieve an excellent outcome. The best place that I started was in hydrotherapy. I was here for 3 times a week with an experienced hydrotherapist, and it was brilliant to maintain fitness in a non-weight bearing environment. I was able to control my joint effusion, my soft tissue edema, and accelerate my neurovascular healing, particularly because of the hydrostatic pressure of the water. 4 months of progressive rehab, I was able to walk around and return to work in a phased return program. I completed a year of on-land training and proprioceptive training and returned to sports. After 2 years, I managed to get onto the slopes again. So that was a massive success. Often rehabilitation of athletes is easier than patients that are either dyspraxic or elderly. Athletes are used to training to make themselves stronger, faster, and more energy efficient. Whereas patients that are dyspraxic or elderly are often afraid and not sure how to move and what is the best thing to do. So I find the key to rehabilitating these kind of patients is to make the rehab as individualized as possible, relatable, enjoyable, so that exercise becomes a lifestyle of well-being. The key to this starts with rehabilitation. So ideally, they're preparing for surgery, but not only surgery, but for the physical therapy that will start afterwards. Prehab gives them time and the resources to optimize their functional capacity by cardiorespiratory function, by improving their muscle function, and changing any modifiable risk factors that can limit their recovery. It also gives them time to build a rapport with the physio, because sometimes the environment can become quite intimidating. It allows them to practice the exercises before surgery, before they're in pain, and it gives you time to get a rapport with the patient so you can make their rehab a bit more fun, less intimidating. I use lots of analogies and imagery. I explain the journey of rehabilitation as like the stock market. Generally, the economy is improving year on year. There are going to be these little dips and plateaus and crashes. My job is to smooth this process out as quickly as possible to get the best outcome. I have 3 quick case studies to talk you through. First one is a 46-year-old solicitor who's a mother of 3 children. She unfortunately sustained a L4, L5 spinal fracture 30 years ago while she was tobogganing, which resulted in a 3-level spinal fusion, luckily no neurological dysfunction. She's massively fear avoidance. She came to physiotherapy so she could drive the 45-minute school run twice a day without pain. So I found using a Pilates reformer gave her the support of her lumbar spine while individually strengthening her legs. Now Pilates has become her lifestyle, and the need for her to use regular painkillers and a lumbar support has stopped. Now she can drive for 4 hours, no problem. My second case study is an author. She unfortunately sustained a complex elbow joint fracture with both ulnar and radial nerve damage. This happened while she was trying to learn how to ski and was involved in a collision, unfortunately by someone else. Unfortunately, the aggravating position for her is what is required for writing and typing. So our rehab focus is on elbow extension, supination, and radial deviation. After we did some basic range and strengthening exercises, I introduced more kinetic chain and goal-targeted exercises, such as lawn bowls. So I get her to aim for a target with a nice soft ball. Tempo bowling, so we use a soccer ball to knock over water bottles for power production, and then incorporating her kinetic chain, doing simple underhand volleyball serves, and she can aim for a nice target. In addition, to improve her bone health, we started a return to run program after she was comfortable with that. But with this, we had to modify her running action. So we had to maintain the arm in supination, keep the elbow static, and drive from the shoulder. Now her husband joins her for her running, her regular runs, and she says it's brilliant for their mental health. So that's great. My third example is, he's not an athlete, but we see lots of these patients. He unfortunately fractured his hip while slipping on the ice. He's very anxious about his independence. So we both have a passion for cricket. So take him away from the snow, put him in a nice happy imagery. So instead of doing lunges, we do cover drives. Instead of between walking shuttle runs, we do running between the wickets to get that winning run. Or squats become fielding in the slips. So, really getting time onto that hip. And balance is bowling action. He does a lot more than just 3 sets of 12 exercises. I make it really fun. I enjoy it. He enjoys it. We get lots of laughter. And now he can enjoy background cricket with his grandkids. And he's definitely got his independence. I find getting the best outcome rehab requires a lot of careful observation of both effort and the quality of the exercise. So I'll look at heart rates, I'll look at their sweating profile, their breathing rhythm, their breathing rate, their breathing depth, the actual muscle contraction, are they recruiting the right muscles, and what is the movement quality like. Process is a long process, and tissue healing takes different times, so different phases. So I continue to monitor edema, joint diffusion, joint range, muscle strength, muscle capacity, muscle endurance, how many reps they can do, what weights they can carry, and more complex quality of movement like their force velocity curve. I use all these factors to determine, do I need to push the patient a little bit more? Do I need to rein them in a little bit? Do I have to focus on their quality a little bit more? We can use all this amazing data to compare either to the unaffected limb or age match to normative data of a cohort of similar ability. So in summary, my key concept for getting the best functional outcome for after injury is a massive team effort. It's the physio, it's the patient, it's the patient's family, it's the surgeon, it's the SEM, doctor, it's a radiologist. Everyone's involved. The timing from injury, the sooner the injury, the better. Rehabilitation is absolutely key. And then rehab must be individualized, must be personable, must be relatable, must be enjoyable. So they do it. And concerted effort is really encouraged, but carefully monitored. The progress, because it's a stage effect, must be measured, recorded, and adjusted accordingly. This is all to promote a lifestyle of well-being. Physio doesn't just stop after 4 or 5 sessions. You can stop recording. Thank you.
Some great presentations. It's not the same as all being together face to face, but it's nice to see all of you and to hear from you. I think we're going to open up to questions. I've seen quite a few questions come through on the chat, so keep those coming if you can. A big thank you before we go to the questions to Emily Brown, to Elise and Kelly, and to Aaron for putting this all together. It's been no easy feat getting us all to get off our backsides and do a little bit of work. So thank you to them for putting us on here tonight. So we'll take questions in turn, and so we'll start with Eleanor if we can. So Eleanor, let me start, and then Bevin may wish to pick up. Tell me, is there ever a situation where you see someone and you think, oh my goodness, this person just should not be let loose on the slopes?
That's a very interesting question. I suspect there might be an occasion where one might think that. I suppose as an SEM consultant, I'm always in the business of trying to promote exercise and physical activity, and if that's what they enjoy doing, then I would want to find a way to facilitate that enjoyment in the sort of means of their mental health and their physical well-being. So I would probably hook them up with a very good physio and try and optimize them and sort of risk manage them that way. And Leanne may want to come in, I don't know, on some of the specifics there, but that would be my approach. I wouldn't want to, in an ideal world, we don't want to stop people doing the exercise they love doing. We just want to find a way to support them to do it.
And on that theme, actually, just to continue, is there perhaps like a generic sort of specific sort of thing? Because people can't necessarily access gyms at the moment. They can't necessarily access the sort of face-to-face exercise classes. Is there kind of a generic program, a generic piece of advice you would give? I mean, I think we all, Brits can't get to the slopes, and if they do, they seem to spoil all relationships in Switzerland and other places at the moment. But what would you tend to suggest for people?
So I think the three aspects that you need are. Sorry, I've got small people coming in with an emergency here. Can you?
Yep. We want to see them.
Sorry. So the three aspects are having good cardio fitness beforehand, so building up your general fitness, having good strength endurance. So any workout that is getting your legs strong, but also your trunk and your upper body. And then having good flexibility and stability. And there are lots of online workouts that people can access So yoga is a good sort of whole body exercise that will help prepare for snow sports, because it's addressing strength, it's addressing body awareness and good control. So I would look at those and kind of HIIT type workouts or strength and jumping based workouts. And general fitness, whatever people like to do for that, from a running or a walking program, but build some hill work in there so that you get some leg strength.
Excellent. One more question from me. It's the issue came up in the chat as well. What about helmets? Should anyone now be skiing or snowboarding without a helmet? And is the evidence really that good now that we should all be wearing them? I can remember when I was young, nobody had a helmet on. So the world seems to have changed fairly radically.
I think it's pretty universal now. The evidence is strong there for the papers that have been looked at. In terms of how protective it is, it varies a little bit between the studies, but everyone's advising that now, and it's protective up to between sort of 15 to 60%, depending on which paper you look at. There's some debate as to whether wearing a helmet, the weight of that helmet may increase the risk of associated neck injury, but there's no clear evidence, and certainly not enough evidence to say, oh, I'm not going to wear a helmet. So yeah, I think wear a helmet. It's pretty clear.
Fantastic. Thank you very, very much, Eleanor. If there are any other questions, we might call you back in. We might jump across to Mike now. Mike, thanks for joining us this evening. Quick thought for you. One of the big challenges is patients often contact us from the slopes, and the advice they're getting on the slopes or on the slope side and the advice they're getting in the UK is different, and yet they may struggle to fly back. How do you tend to manage the tension in that situation?
Yeah, it is a very difficult one, Faris, and often the surgeons at the bottom of ski slopes are very keen to operate on the patients, and that's not always the right way forward. However, as you say, if it's a bad injury and if there's difficulties flying, if they've risk of blood clots, etc., then there can be problems about getting people back home. But my advice would always be, if you can get back home, that you should do. I think the surgical community in the UK is much more intellectually stimulated compared with our other surgeons elsewhere, and they understand the importance of physiotherapy and sport and exercise medicine to rehabilitate before intervening surgically. So I would always try and bring them back to the UK if I could.
And on that front, Mike, where are we on what do you tend to do with VT advice and VT prophylaxis? Because often they're on crutches, they're in a brace. It's really quite variable what happens to patients from that point of view. Do you tend to get involved in that advice?
It's very difficult if you're not actually there and there's a doctor on the spot giving them advice. But I'd always try and get them anticoagulated if they're flying back and they're in a brace and they've had a joint injury.
That's great. And talk to me a little bit more about freestyle skiing. My impression is that just seems to lead to a whole load more injuries than we're seeing routinely.
Yeah, freestyle skiing is more dangerous than your average skiing. But if you really want to injure yourself, what you want to do is ski cross or snowboard cross. At the Olympics in ski cross, 1/3 of the athletes that took part had a significant injury that meant that they could no longer continue competing for at least a month afterwards. We had a fractured pelvis, 2 fractured backs, 2 fractured femurs, and a really interesting double spiral fracture of the tibia. So ski cross is where you want to go if you really want to get injured.
Okay, and if you don't want to get injured and you want to go to a dry slope, because that may be all you can sort of access in the UK when you can't travel, any sort of experience of that, and what sort of injuries are we seeing in that setting in snow sports?
Yeah, well, I mean, dry slopes, some of our best skiers and snowboarders started off on dry slopes. And they can be very good. Obviously, they're quite unforgiving if you fall, and skier's thumb is, again, an easy injury to get when you're on a dry ski slope. You put your finger through the hole in the matting, and it pulls off your ulnar collateral ligament, and you can be in trouble. But it's good to go on dry ski slope, particularly if you're going to go abroad and ski on snow, because it's easier to ski on snow than it is on a dry slope, and it does get you fit and get you used to those sort of muscle actions.
So you'd consider that as part of a rehab program or part of a reintegration program using dry slopes?
I would say that would be very, very late rehab. Dry slopes are quite unforgiving, so that would be a long way down the line. I'd prefer people to go back onto snow before they went back onto a dry slope, unless you really, you really had nowhere else to go.
Okay, that's great. Thanks. Thank you very, very much, Mike. I'm just we're still keeping an eye on the chat, so if you've got any more questions for Mike or Eleanor, we can come back to them in due course. Carlos, I've seen a couple of questions come up about hypermobility, and I would guess hypermobile patients ski as much as and snowboard as much as everywhere else, as much as everyone else. Anything different about their management when they've suffered a fracture or dislocation?
No, not really. They probably are at a slight higher risk of injury because their flexibility allows them to put their arm in positions that are very unstable, and whether the cuff is at a mechanical disadvantage to get dynamic stability. So they might get more injuries, in particular instability injuries, dislocations. But other than that, there's really not much difference either in management or rehabilitation.
And what's in terms of instability these days, what's the management when these patients present and they've got instability and a nerve injury? Because we seem to see that quite a lot with the snow sports injuries.
Yes, in actual fact, in traumatic instability, if you examine patients carefully, 50% of them will have a nerve injury. The great thing is that most of them are neuropraxias and will resolve, and usually within a week or two they get better. If you have a dense nerve injury, that's an indication to investigate aggressively and intervene. Brachial plexus MRI will give you an idea of acute injury to the plexus, which is fortunately very uncommon. And if that is the case, then you treat it as any brachial plexus injury, referral to a peripheral nerve injury unit and management. It doesn't affect the management of instability in the sense that you don't necessarily address the instability at that point. But the nerve injury, if it is significant clinically, then must be addressed, yes.
There's a question from the audience, Carlos, about the high risk of recurrence in young patients with instability, and what your threshold is for doing a latter J, as you would say in a rugby player, in a young ski injured or snowboard injured dislocation.
Right, well, yes, there is a very high incidence of recurrence in patients under 16 particularly, but under 23. So under 16, it's close to 100% if you have an acute traumatic dislocation. In under 23s, it's above 80, and definitely over the age of 23, it tends to start flattening out. But those patients have a high chance of recurrence, and therefore, surgical management is really the way forward. Despite that, there's a high risk of recurrence after a surgical repair. So again, in under 16s, if you look at soft tissue stabilizations, there's a 40–50% recurrence rate in those, and that is if they don't go back to rugby. If they go to rugby, then it's much higher. That doesn't mean that it's not worth doing. It just means that they need to be aware of it and maybe manage expectations that way. Regarding Latarjets, well, Latarjets are good procedures in selected cases where there is bone loss or in collision athletes. A skier generally, if there isn't significant bone loss, I wouldn't necessarily consider a Latarjet as my primary operation.
I guess you'd look at what their other activities are outside skiing, depending on what else they do.
Yes, but even then, you know, I'm not a particular fan of Latarjets. Latarjets are procedures that are non-anatomical, that cause quite significant dysfunction of subscapularis and make any further management very, very difficult surgically. They're good when they work, but they're very unforgiving, and there's a high risk of getting complications down the line if they're not done perfectly. So I would be very careful in my patient selection for a Latarjet.
Okay, fantastic. That's really interesting. Thank you, Carlos. I'll hand over to Bevin to take it from here.
Okay, so we'll have a chat with Mike. Just some of the people mentioned some interesting questions around lateral talar process fractures, and when or what investigations would you do on those initially?
So the standard imaging would be the plain radial of an ankle, and interestingly, it's actually best seen on the AP, so the frontal view when we're looking in the region, the subfibular area. The small ossicles can easily be seen because they sit off quite laterally. Hence, they can often be mistaken for a fibular avulsion. But you really need to be able to identify when you're looking at an AP ankle view. You can see the ability of the subtalar joint, and you really need to outline that clearly. But I think if there's a suspicion on plain radiographs, then you're going to have to proceed to 3D imaging. So CT scan. I think most people would prefer a CT scan to starting to have numbers of Broden views at different angles, because with 3D imaging you can process it whatever you want really.
And that's great, thank you. You also mentioned comminuted fractures, and when would you have a clinical suspicion for these? So how would you find that?
I think the clinical picture is the same really. It's someone who's had a suspicious mechanism, so a loading injury with a foot and dorsiflexion. And I have to say the argument about inversion or eversion, so supination or pronation of the hind foot, may be a point for discussion. But if there's dorsiflexion under load and there's tenderness in the subfibular region, so classically anterior and inferior, there are very few structures in that area of the lateral side that can cause pain. One is obviously soft tissue injuries such as lateral ligaments. And really the only bony structures that you're going to have injured are either the lateral talar process or the anterior process of the calcaneum. So those are the sort of main areas to consider.
And how common is avascular necrosis, or how often do you see it in those kind of fractures?
So the lateral, I mean, these are they're small fragments, so it's not an area which is normally quantified in terms of avascular necrosis, particularly around the talus. The main area that gets AVN is the body because of its retrograde blood supply. So the lateral talar process as a peripheral process probably gets its blood supply from the ligament attachment surrounding it. So yes, an avulsed fragment, albeit small, can be blended avascular, particularly when a surgeon detaches any other soft tissue parts to it. But it's not an area that's commonly considered to undergo AVN. It's not an area that classically undergoes a hyperdense, then fragmented process.
Brilliant, thank you.
Mike, there's a question here about whether some injuries are more common in females versus males. Does that apply in your area?
Not that I could give you a figure. I mean, I think the clinical series, as often, there's data presented which will give the demographics of the population at risk, and that will include sex bias versus seniority and experience of in the sport, so recreational, professional, and so on. I can't give whether there is actually a bias for that. I think you need quite large season-based population data to look at that.
And then another question, because you're treating lower limb fractures, people are asking about air embolus from fractures. Is that something you ever see flying home? I'm not familiar with it, but just because it's been asked, I thought better ask you the question.
No, I mean, obviously, I don't know about air embolism. Fat embolism from long bone fractures, I think would be pretty uncommon for the distal tibia, ankle, and foot. I think would be most commonly considered from something like femoral fractures, and not necessarily occurring within I think one would be unlikely to find that with a femoral fracture. But the time frame certainly would be for fat embolism. I'm not aware about an air embolism unless it was a strange open fracture with then changes in pressure and so on.
No, I think air may be being confused with fat in the question.
Yeah.
Thanks, Mike. Shall we jump across to Sam? Is your Wi-Fi working, Sam?
I think he's got. Yeah. Brilliant.
The idea of a question.
Yeah.
Bevin, do you want to go ahead?
Yeah, he might have frozen again, but we can ask it anyway and see. So people were asking about return to play times around this injury and then a subsequent repair. Do you have any? I think we might have.
I don't know if you can hear me, but I've switched my video
yes.
off, so I don't know if that will work better. So really sorry about that. Return to play, I think, was the question, and around plateau fractures. So really depends on the extent of the injury. So plateau fractures, I think, mentioned, vary greatly from a small undisplaced crack or a small avulsion right the way through to the destabilizing injuries we had in that third case that I showed. So for the simpler injuries, probably the quickest you're going to get back will depend on the hemathrosis being reabsorbed, return of range of motion, reconditioning, and probably looking at upwards of 3 months. For the more complex injuries, you could be looking at anything 12 months onwards, depending on, again, the treatment that's necessary and the rehab involved.
Brilliant. And in those particular injuries, particularly the nasty ones that you described, is collapse or bone height loss common? And if so, what do you do about those?
So I guess you mean late collapse after they've been treated operatively. That's what we're trying to avoid, and that's why you look at those X-rays with all of those screws, and you start to think, oh my goodness, what's going on there, and what complications are going to arise from the metalwork. But actually, what we're doing there is we're using those screws almost like a raft underneath the bone to stop it from collapsing down when it starts to be loaded. So you may see small amounts still of subsidence with axial loading, but hopefully that's minimised. If you do lose significant height from one side or the other, then that's going to affect the limb alignment as well as the congruity to a certain extent. And so that might be an indication you're going to need a secondary procedure at some point.
And what would you do in those cases if they did need that? What would you be talking about?
So it depends really on the age of the patient, their aspirations, and what the joint looks like. But we've got options ranging from refixation through to using allograft materials to try to reconstitute the joint, all the way through to joint replacement in the worst kinds of situations. But we try to keep their joint going for as long as possible.
Sam, there's quite a few questions about hemathrosis management. It applies as much, I guess, to my section as yours, but just because you're on at the moment, any thoughts about how frequently we should be aspirating, whether patients should be aspirated before they fly back or whether before they prehabilitate? Do you think there is a positive effect on the joint of removing the blood?
Yeah, I saw those questions in the chat. They're interesting, I guess. I'm scratching my head wondering when the last time I aspirated a hemathrosis was, and I couldn't really remember. I think if you've got an acute injury with a tense hemathrosis, which is causing a great deal of pain, then you can certainly make your patient feel more comfortable by aspirating it. There is, in theory, a risk of the lytic substances in the acute inflammatory response to the hemathrosis exerting an effect on the cartilage. Whether that's real or not in vivo is difficult to judge, and I don't know that that's going to be a determining factor on the patient's outcome. And large, probably best not to, unless you really have to.
And Sam, in terms of all these patients who end up with hardware, how frequent is it that you end up actually having to remove the hardware? It's a question patients often ask. And do you have to schedule something? Do you think about it half the time, or is it just a rare event?
It depends a little bit on the hardware. So with the typical type of plateau fracture, we're using plates on the lateral side of the knee joint, and that's usually buried beneath the musculature of the anterior compartment. And so where you've got good soft tissue coverage between plate and skin, you don't normally get a great deal of irritation, and so certainly we wouldn't schedule routinely to remove that unless it was causing irritation of an overlying structure. With a medial based plate, sometimes that can cause a little bit more irritation, particularly because there's less soft tissue between metal and skin, and movement can cause irritation as a result. And so we remove those more frequently. Again, I don't do it routinely. I wait for it to cause a problem and then take it out.
That's great.
Thanks.
Thanks,
Next, we move on to you, Prof. Haddad. You mentioned with these injuries that you often see bony bruising as well. How do you manage that alongside the ligamentous injury? Do you warn people that it's going to be a longer rehab, or how do you deal with it?
No, so yeah, you're absolutely right. The ski injuries are often really quite high energy through the torque being put through the ski and the boot. And so you see really impressive bone bruising in comparison to some of the other injuries. And I think in reality, it doesn't alter management dramatically. In fact, the big mistake some of the time is that the radiologists, in being helpful, will report it as a microfracture or a subcortical fracture, when actually it's just really an extensive bone bruise with some delineation of it in the subcortical area. And the last thing you want is that patient hopping around for weeks or in a brace for a very long time. You really still want to get them moving, as long as they're not actually loading, running or jumping, which they won't be doing. So it's just a question of being appraised of the fact it's going to take that knee longer to settle down, but otherwise they will typically settle down. What we don't understand is the long-term consequences. I think those big bone bruises and the subchondral damage may well be the precursors of later osteoarthritis. So I think you've just got to bear that in mind when we're treating patients. We're doing everything we can to return that joint to normal, but the die may already be cast in terms of later damage. But you do see some very impressive ski knees with, both collaterals partially injured, ACL torn, big bone bruises, meniscal tears, just because the energy going through the knee is massive.
And you mentioned that you've seen ACL tears heal, and that you've had some rare cases where you sort of seen that resolution. Do they have the same integrity? Do they have the same function when you're looking at those?
So it's a really interesting thing to look at, because you don't get to see a whole load of them. And in general, the very active, very sporty individual, particularly the elites, don't have time to wait and find out if their ACL will scar up. So I think in reality, there is a small subsection of patients, probably the same subsection, who do well with repair, who have a femoral avulsion where it just peels off the femoral side. And if you're lucky, it will stick back down and function pretty normally. And I've got a collection of those patients who've done incredibly well. They basically got back to normal function. I think we've got to be really pragmatic with the elites. Need one form of treatment, and then for most people, there is a sort of bit of a wait and see how the knee settles down. It probably is better for them to prehab anyway. And some of them won't need reconstruction, either because they stabilize or because they change what they do. If you suddenly give your Sunday morning back to your family, you may not get it back to go out and twist and turn on AstroTurf ever again, or to get back out on the slope. So I think it's worth waiting and seeing how patients settle. But the femoral avulsions, in my experience, often are ones that just scar up and do pretty well. And there's often a load of intrasubstance tears as well that can just about heal, but you just can't assume that they're going to heal. The key thing is to keep the patient under review, rehabilitate them, then re-examine them. Because the flip side is the worst thing is to manage someone with the expectation they'll go back to normal and then have them fail whenever they get themselves back in a pivoting situation.
Brilliant. And somebody's just asked, do you see an increase in osteochondral defects or chondral defects around skiers with ACL ruptures? Is that common? And if so, how would you manage that, or would that change your management?
So all the associated injuries are managed on their merits. What they will do is generally push you down if they are displaced, for example, they push you down an interventional route, and so you'll tend to fix everything at the same time. What we see a great deal is the compression injury on the femoral condyle laterally from the sort of high energy pivot. So they have a complete dip in the lateral femoral condyle. But if someone's got a genuine osteochondral injury as opposed to an osteochondral lesion, so an osteochondral lesion is really a bad bone bruise. An osteochondral injury is where the cartilage plus bone is demarcated and potentially unstable. Then we would tend to fix those, and that would push us towards an earlier reconstruction. That's where the nuance comes in, because people want broad rules and they want to say, okay, well, you've torn your ACL, let's manage you this way. You must go off and settle the knee down, do X, Y, or Z. But actually, if you've got an osteochondral lesion, defect, or if you've got an unstable meniscal tear, then there may be a strong argument for doing something earlier for the long-term health of that knee.
Brilliant. Lovely, thank you. And next we can move on to Leanne, will we?
Leave the best till last.
Yeah. So Leanne, somebody's actually asked something which is probably quite relevant at the moment when everybody's staring at computer screens. How do you keep people sort of positive and motivated during rehab, particularly in this time, maybe if you're seeing people who have potentially come back from the slopes and are injured and are having to do everything online and at home?
Well, we're lucky we can actually see them face to face, so that's amazing to have. With no gyms open, we've got all the gym in-house, so that's a massive advantage. I try to see them as regularly as possible, so once a week or twice a week, just to really get their rehab just cemented. I try for longer sessions as possible, so generally I try for an hour. By the time they've got changed and had a sip and done their sanitizing, I think, that's when we get half an hour, 20 minutes, you just can't get enough done. So I try as regularly as possible and as long as possible, and I push them really hard. So I challenge them and I observe everything that I can. So their breathing rate, their rhythm, everything, their heart rate, and I push them hard. So it's nice to be able to use all the different weights and vary the weights. We've got leg press. So we've got lots of instruments to measure their progress. So that's kind of the key for me. Try to keep it as fun as possible and as personable. If they're enjoying it, if they can relate to it, they'll do it and their progress will be so much better. And if they have to be on videos are fun. So, it's quite nice to see their home environment, see what they can, what space they've got, what equipment they've got or don't have. And you can see around their room what they can use. So I become quite creative. And often they feel more relaxed at home. So often it's a really nice environment for them to use as well. And it saves their commute. Sometimes the commute coming in is tricky for them. So it does save that time and they can focus that time on their rehab rather than trying to mission to get somewhere.
Brilliant. And what do you do about their apprehension around re-injury when you're going through the rehabilitation stage?
So I think re-injury is a big concern. So my aim and kind of the whole MDT's aim is to prevent more injury. So you want to make them stronger, faster, more resilient than before the injury, so they don't have another injury. So you want to make them as robust as possible. So really want to make them as strong, as flexible, and have as much muscle endurance as possible, just so that they don't injure. And there's loads of preventative rehab as well. So we reintroduce that after a lot of reactive rehab after they've injured. So most people say they're much stronger and fitter than they were before the injury. So that's That's the aim. And we try and make it to become a lifestyle. So it's not just, okay, you've done your 5-6 months, a year of physio, and then it stops. It's kind of building it into their day-to-day routine. So making it as integrated as possible.
Brilliant, thank you. And somebody mentioned, is there ever a time where you tell somebody absolutely no way, don't go on the slopes?
No, I think I agree with Eleanor. Eleanor mentioned this as well. Our job is to promote exercise, promote movement. So maybe you would modify it, say maybe don't go for a whole week if it's the slopes, maybe start on the blue slopes, and just get their rehab as robust as possible so that you are confident, they are confident, they've got all the strength markers, they've got all the endurance markers so they can go on. I've been there, I've been injured and I was nervous and I worked really hard, so I know you can do it. And sometimes if skiing or the snow sports is not the idea, you find an alternative for them. And a lot of people will self-select that for themselves. So you try and encourage exercise as much as possible.
Brilliant, thank you.
That's great, Leanne. Thanks. I think it's coming up to 8:30. It's been a great session. Thank you all for making the time. Thanks again to Emily, Kelly, Elise, and Aaron for putting this together, and thanks to everyone who's joined us this evening and for all their questions on the chat. I think as many of you will know, ISEH is easily accessible on the web and on social media, and we're happy to take further questions there and for you to keep in touch with us. I think for now it's been a couple of hours and we don't want to take up any more of your evening, so a huge thank you from me to Bevin, who's been ever present for 2 nights running this webinar. So a big thank you to Bevin, and a big thank you to all the speakers for some excellent and very thought-provoking presentations. I really enjoyed this evening. I'm desperately hoping that next time we do this, we will all be face-to-face together again next January. But in the interim, I hope that some people who've been listening will manage to make it to the slopes and that everybody can stay safe and healthy and that we all meet again soon. So thanks very much, everybody.